Good afternoon, and welcome to the Bright Idea webinar series brought to you by Intellect Resources. I'm pleased to be your moderator today. My name is Tiffany Crenshaw. I'm the President and CEO of Intellect Resources. We are a recruiting and consulting company specializing in healthcare IT. If you will, today we are happy to take questions at the end of our webinar. And if you will take a look in the bottom left-hand part of your screen, you'll see a chat section. If you will please enter your questions there, I can promptly, or at the end of the webinar, we can pose those questions to Rob Hutchinson, our special guest, as well as his guest today. So please post your questions there in chat throughout, and at the end of the presentation, we will move forward and ask those questions. Okay, moving right along, I'd like to introduce Rob Hutchinson. He is a friend and colleague in our industry. He is co-founder and current CEO of Proficient Health. Additionally, he's a 25-year veteran in our industry and a true entrepreneur. This is the fourth company that he has founded and run in his history. Needless to say, I think Rob is very skilled in recognizing opportunity, and today he's going to discuss an opportunity for the healthcare industry to manage communication and data with providers that are not in your EHR network. So without further ado, I'm going to pass the controls to Rob, and I'm going to let him take the webinar from here. Thank you, Rob.
Thank you, Tiffany. We're so proud to be a part of this webinar series. And as Tiffany mentioned, today I'm part of Proficient Health. And I will sorry, I'm having some technical difficulty here moving the screens, but if we can advance to the next slide, can't seem to, thank you. We wanted to start by talking a little bit about Proficient Health is specializing today in healthcare IT workflow solutions and software and services for the secure and efficient exchange of information. We really focus on three areas: improving communication, improving access, and ultimately helping organizations build the single patient record. And what we'll be talking about today really ties into the fact that we're all seeing data become more and more critical to the administration of healthcare delivery and reimbursement. We're all hearing acronyms like ACOs and population health management strategies in today's healthcare marketplace. What I wanted to emphasize prior to getting started today is we do have two very special guests, Karen Ellis and Lisa Harrison, with us from Bon Secours Health System, the St. Francis operation in Greenville, South Carolina. They will be presenting later as we go through the various slides here. And that really will be the most important part for you today, is to hear Karen and Lisa talk through the gaps that they found in their electronic health system on EMR platform and what they've done to help fill those gaps. So what we'd like to talk about first to get started today, sorry, I'm still having some delays with the slides. What we'd like to talk about first, and what you'll learn today that you may or may not have seen with your EMR platform, is those gaps. And we'd like to talk about kind of the definition of the gaps to get started with. We define those through research in the marketplace with hospitals and large physician practices back in the period between 2007 and 2008 with various hospitals and physician practices that had already successfully implemented their electronic medical record platform and had been operating in that environment for some time. We'd like to kind of talk through those, and we're going to give you examples today with Karen and Lisa for the Bon Secours system. Also talk about two other large systems that are in North Carolina, the Cone Health System and the Vidant Health System in Greenville, North Carolina. We do have case studies that document a significant impact that these gaps cause those organizations and effective solutions and strategies that you may implement to overcome those gaps. Next, we'd like to talk a little bit about an article that is very recent and relevant for everyone, and that was in the September 30th issue of the New York Times. The title, "Doctors Find Barriers to Sharing Digital Medical Records." And I would encourage everyone here to take a look at that article. You can find that online. And it does demonstrate that there's a significant problem in the marketplace today that has not been overcome by many organizations. The basis of our original research several years ago, 5 and 6 years ago, indicated this same problem, and there's been very slow adoption to technology to overcome this problem. We'll move to the next slide. Talking through these gaps today, we'll talk really about the impact organizations are experiencing from small physician practices to large teaching hospitals, and what the impact their organization is experiencing financially through the lack of access to information and the error-prone workflow that can impact the care delivery and the satisfaction on the physician side, as well as the patient satisfaction. What I'd like to do now is talk about a typical paper-based workflow for single MRI. We did studies on dozens of types of workflows related to procedures that were administered from an inpatient and an outpatient process for healthcare delivery organizations, and the financial and satisfaction rating impact they experience. So what I'd like to do is walk through these. You'll notice that each one of these has a dollar sign associated with the step in the process. And where this process begins or has begun in many organizations is by the creation of paper. An order is received or printed or copied through a referral that may be faxed into the organization or even brought by a courier. So at that very first point in the referral or new process for an order for a patient, paper begins that process. We documented up to 35% of orders in many organizations were missing critical components for the care delivery and for the financial reimbursement of those services. That started a process to send information and request back, typically by fax or by a phone call. Information came back in either through a courier or a fax or a phone call. More paper was created, copies were made, and information was rekeyed into other systems. All of these steps were very demanding from a labor and a resource perspective. Confirmations were sent back. Copies went to various departments, both on the clinical and financial side, and copies of the documents were scanned into the electronic medical record platform, incurring additional expense. Typically, the downstream effect of creating all this paper, we found, was a significant impact because the paper had to be either moved to off-site storage or it needed to be securely shredded, and many times that was on-site shredding. And there is a difference with on- and off-site shredding, partially due to the expense and also due to the environmental impact that we documented. And a lot of people are curious about that. And on-site shredding usually involves large diesel-driven vehicles being driven onto healthcare facilities or properties, creating some environmental issues there. Those costs were documented, and really where all this began with the paper-based process started with the unnecessary conversion of electronic data into paper. And again, if we want to reference back to that New York Times article, only about 14% of physicians have a proven methodology, either through CPOE or another technology, to effectively communicate. The big takeaway there is that doesn't happen once or twice a day. It can happen thousands of times per week or per month, depending on the size of the operation. And that ties really into the financial cost or impact that that organization experiences by creating paper and paper-based workflows that ultimately create a gap in the electronic health record. They create a large gap because paper is disparate and it's not accessible across the organization. And it's expensive for various personnel to put that information into the EMR. Studies were done following significant work. Sorry, the slides are jumping ahead here somehow. Studies were continue to be conducted, and impacts of up to $3 million per year were documented across multiple service lines or departments where, I think this is still moving slowly here, I apologize. You should see a slide that says the financial cost now. Impacts of up to $3 million a year, and these weren't from a full enterprise study. These were studies that were done on large departments or service lines in various size hospitals. So you see that that's no small loss for a healthcare operation, and those dollars could be used for either equipment or additional personnel instead of write-offs and things like that we've experienced. We found organizations writing off $30,000 to $50,000 a month due to lack of access to the information needed in the patient financial services department, for example. There was significant time found in these studies allocated to copying records, scanning records, and rekeying information. All of those created a significant impact on the human resources that were dedicated to these paper-based processes. Also requesting information from off-site vendors or off-site storage or out of legacy systems. Those all required significant cost, time, and lack of access to critical information, both for clinical care delivery and the financial reimbursement of the services. Last but not least, there was significant documentation found from the cost of paper, toner, and operating the equipment that created all of those documents. And again, as we talk through this today, and I think you'll hear from Karen and Lisa, all of this ties into really our title, the myth of the paperless EMR. We found one organization after another that had said after they fully implemented their EMR, they still had significant paper-based workflows that were impacting both clinical and financial aspects of their organization. The next slide, titled Establishing a Simple Technology Bridge, really gives you an overview, and you all receive a copy of this presentation along with the white paper behind this. This gives you a simple overview of various alternatives and their role in helping bridge to a paperless environment in a single paperless workflow through your EMR and leveraging your EMR investment. What we're driving to in this presentation today is helping organizations look for alternative 3, combining various resources and technologies that are available to you today into a more accessible environment that allows you to seamlessly share information. Thank you. And with that, I'd like to introduce Karen Ellis. Karen is with the Bon Secours St. Francis operation in Greenville, South Carolina, and is the Assistant Director of Information Services. She is a 30-year veteran of the field of healthcare information technology, and holds a bachelor degree in medical technology and a master's degree in health systems management. So with that, I will turn the presentation over to Karen and Lisa.
Thanks, Rob, for that nice introduction. Joining me today is Lisa Harrison, who's my senior analyst responsible for supporting the Proficient application. Lisa's a former radiology tech who has experience both in the clinical setting as well as in the imaging vendor world. For those of you who aren't familiar with us, Bon Secours St. Francis Health System is headquartered in Greenville, South Carolina, and we're part of the Bon Secours Health System Incorporated based out of Marriottsville, Maryland. Bon Secours St. Francis Health System consists of two full-time hospitals, our St. Francis Downtown and our St. Francis Eastside hospitals, as well as numerous other facilities. Our health system provides various ancillary services to affiliated providers and community providers as well. While both of our hospitals are on a shared EMR, at the time of the case study, none of our affiliated providers were on that same system, nor were any of our community providers. In 2010, an operational initiative was launched to create a concierge service to improve the patient and physician experience related to the scheduling of certain ancillary procedures. I want to emphasize that this was not an IT initiative, but an operational initiative which was driven by the department. In its initial phases, a pilot group of affiliated providers would be provided a special phone number and fax number that would have a dedicated concierge who was ready to address their scheduling needs immediately. At the time of its launch, though, the program relied on a cumbersome paper-based processes that were triggered when those physician orders were faxed to the hospital. Now, even though the faxes were sent back to a fax server, there was no reliable way for us to store them, track them, or distribute them. So our St. Francis Hospital Patient Access Department would receive and log each fax, handle pre-certification, and proactively call each patient to schedule the services. If a physician's office called saying they had sent a fax but we couldn't find it, we had no way of confirming that we had indeed received it or track what had happened to it. Faxes could be accidentally deleted. Many a time we had an irate physician office assuring us that most certainly they had sent us a fax on a patient, and why hadn't we scheduled that patient? In order to communicate to another department, we had to print out the fax and manually fax it to them. In order to effectively run the program, it was clear that we needed a change. So in 2011, the St. Francis Patient Access Department adopted a web-based solution that automatically captures paper-based orders as electronic files. These are easy to track, access, and share 24/7. The concierge staff log into a secure portal and they work their assigned queues of incoming faxes. They review the orders for completeness, and if the order is incomplete, they can do something called ricochet fax that sends them back to the provider with a canned message indicating what information is missing. That paper contains a barcode, so when the provider then faxes the document back, the process can pick up where it had left off and the record can be indexed. A call is made to the patient, and as the procedure is then scheduled into our EMR, the HL7 ADT interface sends back the demographic information, allowing the concierge to associate that order with the correct patient. The completed order can then be exported with a few simple steps back to our EMR. If another department also needs the document for any reason, it can be sent to another queue for additional work that might need to be done with the document. We no longer lose those faxes, whether it's by accidental deletion or by being unable to tell a provider for certain if we received a certain fax or not. As our workflows have changed with time, we've been able to reconfigure our queues to meet our changing needs. We now have many of our original affiliated providers on the same EMR platform as the hospital. Thus, we've eliminated the need to fax those particular orders. But that has allowed us to expand our dedicated concierge service to more of our remaining affiliated providers and even community providers. Several years ago, a third-party study was conducted by Premier, which is a healthcare alliance, and it showed that the St. Francis Patient Access Team was operating at nearly twice the productivity level of other allied hospitals. 10 staffers could manage the same volume of work that other hospitals needed 19.75 employees to accomplish. Other benefits that study quantified were that they saw a labor productivity advantage of 196%, labor cost savings of more than $360,000 annually, and a total return on the annual investment in the service in less than 2 weeks. While the St. Francis Patient Access Department was the first to adopt this paperless approach, since that time of the case study, several other St. Francis departments have adopted the same paperless approach for their unique needs. We have found numerous other ways to use this web-based application for the capture, storage, and distribution of faxes. So with that, Rob, I'll turn it back to you.
Thank you, Karen and Lisa. I will say you heard Karen mention that this was not an information systems initiative, that this was initiated in a department. And that's something that we've seen through research in a variety of organizations and is a common theme through the next two case studies that you'll look at here. The Cone Health System is the next case study, and then ultimately the Vidant system. What I will say for Karen and Lisa, the reason that we've seen such tremendous success in the Bon Secours operation is because ultimately this did transfer into the information systems area where there was a very strategic view taken of what information is flowing through the organization, what imports and exports need to occur from a very high level with the platform they use to manage their records, and ultimately what is the data that they want to take away from that. So I think that's a very important theme when you're choosing solutions to think through. The Cone system that I'll hit, the Cone Health System based in Greensboro, North Carolina, that I'll touch on here. This started for this operation, and this study was based around lost and misplaced referrals and surgical services. In a similar way to Bon Secours, physicians, patients, caregivers, and physician extenders were all frustrated. A significant number of these fax referrals were lost or not accessible at the point of care, and ultimately impacted care delivery and the timeliness of those services. There was also a downstream effect that Cone experienced and reported around the financial side through patient financial services not having access to these documents that had previously been faxed in. Ultimately, the results were what was important to them, and we spoke with the Director of Surgical Services months later one evening where she reported she had held a meeting with a number of the key surgical practices in Greensboro and told them they had implemented technology to resolve the problems they had. And it was kind of funny because she said, they said, well, we don't know what you did, but whatever you did is working, and we're not having these problems anymore like we did months or years in the years past. It did produce significant time savings and ultimately scaled through the Cone Health System through various other service lines and departments, and ultimately did reside in the Information Systems Department in that operation as well. I'll skip ahead to the Vidant Health System. very large non-hospital system based in eastern North Carolina or Greenville, North Carolina. Similar problems in patient access, lost information, delays, problems getting the information into their EMR. Solutions were developed there really designed to improve the physician and patient satisfaction and create all the advantages we've talked about today of a paper-free environment. Ultimately, this did improve staff morale. It helped retain personnel and really improve the environment that people were working in by improving the access to the information they needed to do their jobs. I'll jump now to a slide titled Selecting a Best-in-Class Solution. An important piece of this that we've talked about several times today is involving key resources and personnel in the selection process. Selecting a best-in-class solution is complex, and it's a very important process because once you select that, you can hope that that will be scalable to multiple areas in the organization and ultimately be something that will last and be part of your what we kind of term mission-critical workflows for your operation. I won't read all of the various components here to this because you will receive a copy of it, but a very important takeaway here is including your internal and external communication partners in the process. Think about who inside your organization needs the same information you do. Is it typically the lab? Is it typically the radiology department? Is it patient financial services? What area needs this information, and who do you communicate with routinely inside your operation, and who do you communicate with on a routine basis outside of your operation? To make sure when you're choosing tools to think through those components. Obviously making sure that you have 24-hour tech support. The organization you choose has an infrastructure that is HIPAA compliant and is scalable and capable of helping you achieve your goals that you design on the front end of making that selection. Next, I'll jump to the final thoughts that we have from all the research that we've done and the organizations that we've worked with. We have worked across dozens of EMR platforms now and found incredible benefits that the organizations have experienced by implementing these platforms. We have found gaps both in these internal and external communications related to the platforms that have been implemented. Unfortunately, they do often create paper-based processes. Solutions are available. They typically start with services to evaluate what you're doing today and help you design goals to take you to the future. That may be a future operating one department that has a very high volume of workflow. It may be to help you collect and aggregate and report on data through a local HCO or whatever that may be. But we do hope you learn today from our guests from Bon Secours, Lisa and Karen, that you can achieve very impactful results across your organization by using technology. Set clear and measurable goals. That's what we've seen people do that have been very effective as they've implemented technology. And looking for flexible solutions and ones that do support your goals that you design. Now I think we can take questions, comments, or any feedback we have from the audience today.
So thank you very much, Rob, Lisa, and Karen. We enjoyed your comments, and I have 3 questions that have already come across the board. Actually, there are 4 now. So please go ahead and add to the chat as we begin talking. So, Rob, I'll start with the first one. Is this the tip of the iceberg? Are there hundreds of other paper processes that are not captured in EHR? Hold on, it's multi-parts. Let me finish. How would a system start if they wanted to start tracking other processes down? And in your experience, which area is better suited to drive this initiative? Would it be operations or IT?
That's a really great three-part question. I will start the answer, but I would love Lisa and Karen to chime in. They're right in the minutia, in the middle of workflows that are very intricate, involved, and ultimately take them to their utopian goal of creating that single patient record. I think the first part of that is I do believe it is the tip of the iceberg. We've worked with organizations that have experienced problems that are so bad in their medical community that have forced them to make changes. As they've implemented solutions, they've found dozens of other workflows across their organizations that could benefit from the same or similar solutions being implemented. And Karen or Lisa, if you want to chime in on that and also make a comment around IT and IS involvement, that would be great.
This is Lisa Harrison. As far as the involvement in regards to IT, we found a lot of success with that. In our environment, we initially started with, as Karen indicated, with the operational side, but the IT side really has a good, strong connection with the IT side over at the folks there at Proficient, and so that in itself was definitely a benefit. And as far as where to start in a facility, I find that each department has its own needs as far as tracking this documentation. We started here in the patient access concierge area, and we found that originally when they started operationally within their own department, they had some needs there, and we then took over IT and we improved those workflows tremendously. They already had an initial benefit, and then we took them to the next level. Other departments saw those benefits, one being in our OB department for scheduling OB patients to deliver, and then most recently we implemented this process with our outpatient rehab. We have multiple facilities here in the Greenville area, and it has really improved their ability to track these orders and papers of various types to schedule patients within our system.
Okay, great. All right, we have a bunch of questions, and I'm going to try to aggregate these together. They're all really related to the EMR and EHR companies. And why don't we start with this one is, is your product vendor agnostic, or any of your other competitors? Are you vendor agnostic when you're chasing down items to be paperless here?
Thanks, Tiffany. Yes, that's part of the architecture and design of the system that we've created is to create a platform that is agnostic and can work across multiple platforms. So yes.
Okay, good. So then the next question is, well, let me make sure. I think you've answered that one. But how have the EHR vendors been in working with you? Have they been cooperative or have they been challenging in making sure that the information that you're collecting and making it available into the EHR, I mean, how have they been to work with, and any advice in trying to negotiate or work with them in this type project?
Well, I have two comments there. First, the general comment that they have been very cooperative. I think their cooperation stems from their customer and not from working with Proficient. And I'll just give you an example. If Lisa or Karen were to call their vendor and say that they're working with another vendor, that seems to facilitate a very productive process going forward. But we've had great results with numerous platforms working with, and I think it's become very commonplace over the last 5 years for various vendors to work together.
Okay. All right, one more on that vein, and I think I've caught all the ones asking about the EHRs. This one is, what EMR, EHR companies have you seen that have the biggest gaps?
I don't know that I really want to answer that.
Okay.
I don't think that's fair to them, because I think different organizations use their EHR or EMR in different ways, and their goals and strategy may be very different than someone else's. But we've worked with countless different EMRs at this point, and they all have strengths and weaknesses.
And Rob, I'm gonna, if you don't mind, I'll make an observation on that. I think that, as you said, it depends on how you set up your EMR, and I mean, there's a lot of decisions that get made. The areas that we're having the paper is, for example, from our community physicians. Well, if the way that you have structured your EMR is that you're allowing your community physicians onto some sort of portal and allow them to put orders in via that portal, you're not going to have your paper. But if your facility has made a decision that you're not going to allow your community physicians to be putting orders in, then you're going to have your paper. So some of those are not necessarily limitations of the EHR. It's more purposely the way you have chosen to set it up.
That's a great point, Karen. Thank you.
I would agree wholeheartedly with that, Karen. And Karen, I think that you can probably take the lead on the next question, but it's, what is the typical timeline on a project that Rob has described? So maybe you can back up again. It sounded like it might have been over a couple of year period, but maybe you can get into more details.
I'm actually going to defer to Rob himself. That our initial implementation with them, indeed, was 4 or 5 years ago. Not only do you have the implementation piece, but if you're designing an interface in the first place, there's work on your side as well as on their side. I don't have at my fingertip how quick the initial one versus these days, as we've added a new department on. Most certainly it's a lot faster because, for example, with our ADT interface, we're simply adding an additional department that we're going to be feeding that across our ADT interface that we weren't sending initially. And so, I mean, Lisa,
I did outpatient rehab in 3 weeks.
Right.
Because we already had the feed. So we, developed a workflow, created what was needed within the Proficient Health application, which was very easy to do, training, and go live, because the groundwork, the foundation of the interfaces is already there. As a matter of fact, we're getting all ADT. So.
Now, when we did our initial one, it may well have taken us 6 to 9 months to get that up and running. So it's going to vary.
Yeah, I think that I'll just add one point to sum that up. Karen and Lisa said it best. It really depends. We've implemented small operations in 2 weeks, but there are 3 distinct steps to that, and those are implementation services, and those are all designed and architected for the best outcome. So those implementation services can take several weeks. There are training processes for administrators, super users, and users, and then an actual go live. And those really can range from 2 weeks to several months, depending on the complexity and the goals around that implementation.
Okay, great, great. Okay, I think that I have covered all the questions here, so I would like to go ahead and wrap this up and just say that we appreciate Rob and your guests for joining us. I think what you shared today was a great reminder that we all still have a lot of work to do to go truly paperless, that there are still so many corners in the healthcare system that need some attention. And it's nice to know that there are some quick and easy solutions that also have a good ROI to helping us tackle that. So thank you all for your presentation, and thank you to all our listeners for joining us today. Shortly, you'll receive a thank you email, and within the next several days, you'll receive a copy of the PowerPoint deck as well as a white paper that was put together by Proficient Health. Hope you enjoyed these materials. Again, thank you, and have a wonderful afternoon.